right, let's shift to hospitals. There's a federal regulation passed many years ago, EMTALA, and I can't remember what it stands for. I'm sure Jimmy knows. But it's the regulation. Avik Roy, writing in Forbes magazine, said this is probably the biggest unfunded mandate in our country has ever passed. It basically says if I go into the hospital, they have to see me whether I can pay the bills or not. And because of medical malpractice risks and all that other thing, they probably going to have to run a lot of tests before they let me go. And so it's a huge problem for a hospital, any hospital, because you're not getting paid for your services in many cases. So from a business perspective, in a rural area, you know, we hear every day rural hospitals around the country and here in Georgia closing. Walk us through, Jimmy, sort of the day in the life of a businessman who's trying to run a hospital and the financial situation and the challenges that you have.
Okay. Is this on? Okay. Thank you, Kelly. It's interesting, as each one of you have spoken, I've thought about where I would start describing the issues facing a hospital, and it's shifted between each of the three of you. And you're right, I do know what EMTALA stands for, but I'm not going to tell you today. So Brian talked about price, and I think about price and I think about cost. And I'll try to lay out some framework as I touch on each of the three of your comments and come back to yours and go from there. So when we think about a hospital and we think about cost, we know that cost of healthcare in the U.S. outruns inflation every year. In recent years, we've been tracking around 12%. And by the way, the United States has the highest healthcare inflationary rate of any developed country in the world. So we have to stop and ask ourselves, why is that? Some would like to think it's because we deliver more care and better care than anybody else in the world, but that's not exactly accurate because our healthcare outcomes are not the best in the world necessarily. So what's going on? Why do we have all this cost? Why are rural hospitals, especially in Georgia, you know, we're one of the third worst, and we're one of the three of the highest states at risk in the country. We know that the price is inefficient and higher than it should be. The question is, why do we have all these complex problems? To start with, a hospital has tremendously high fixed cost. Think about the capital equipment and the staffing cost. The cost to serve one more patient, the variable cost, is extremely low. And I'm going to come back to the example in the emergency room in a minute. It's extremely low. So I think part of the problem is we have built this elaborate and high-cost distribution system where we're replicating costs in almost every single hospital, even if they're in rural Georgia, only 30 miles apart, because it's fair to say that every county wants their own hospital. Some have closed, and it is detrimental to the economy and the welfare and the well-being of the citizens in that community when it happens. But do we have enough revenue, and does the business model still support every single county having a hospital? We'd like to think so, but can we practically provide? Can we provide it? That's the question. So maybe it's time to start rethinking the whole distribution system. And I think that's what you and I have talked about earlier today. There is no doubt that the lowest cost delivery is in the physician's office. There's no doubt about it. So Kelly, going back to your comment of EMTALA, when a patient presents at an emergency room, it's a federal law that they have to be triaged and assessed. Now, what some people don't realize, if that patient's needs are deemed non-emergent, they can be denied care. If they're deemed emergent, they have to be treated regardless of the ability to pay. Most hospitals treat the patient regardless. One, they're afraid of the liability if they're wrong, and it turns out being emergent. But secondly, many hospitals are still under the mission that we're going to treat every patient regardless of their ability to pay and other variables that enter into the equation. And that goes back to the original Hill-Burton Act from the late 50s that built the rural hospitals across the country. Our mission still performs as though we were under the Hill-Burton Act because that's how our hospital was built. Now, what's interesting about the EMTALA and the distribution system and the shortage of physicians and the uninsured patients, many of them go to the emergency rooms now because they don't have insurance, which means they don't have access to a private practice physician, a clinical physician, whether they're private practice or owned by the hospital. And it turns out that 80% of our emergency room visits are non-emergent. Only 20% are emergencies. So we have, in effect, evolved into an urgent care clinic that's capable of taking care of emergencies. But we have the staff and the equipment for the emergencies, which raises the fixed cost of that setting versus one of your clinics. Our fixed costs are much higher. Therefore, our prices or our charges are much higher. When I first became, so as Kelly mentioned, I come from a private family business. My family has auto dealerships. I'm a third-generation auto dealer. So I'm the local Ford dealer and the CEO of the hospital in Sandersville. Those two don't normally go together. And I realized there were more similarities than I first thought when I got into the business. I've done a lot of research and looked at the business model of rural hospitals in the U.S. and found that there are ways we can make them much more efficient. And when we think about the auto industry, we think about the distribution system. Now, Brian touched on the consolidation that's happening across the country. That consolidation will continue because every provider is looking for scale, the economies of scale. A standalone hospital in rural Georgia, governed by an authority that doesn't have any connection to larger facilities, is limited to what it can achieve in cost savings because it doesn't have scale. Therefore, we move toward the consolidation model. In some cases, that can drive up costs. In other cases, if we think through the distribution model after we achieve the consolidation, we can drive the efficiencies through the system. And this is what we aren't achieving yet. Every little hospital doesn't have to have an MRI machine. It may need a CT scan. And then if you get more remote, maybe you don't even need a CT scan, you just need an X-ray department. Maybe if you get more remote, you don't even have inpatient services. You have this department we call an emergency room that's really functioning as an urgent care center that can transfer emergencies. And we have a hub and spoke model where the further out we push the service, the lower the cost, the more limited the resources are. And as we come back into the system, the more resources are available and perhaps the higher the cost will be.
Makes perfect sense. And tell us about your payer mix, which a lot of hospitals talk about, but the types of patients you have and how much you get reimbursed for those patients.
When I joined the board 14 years ago. 2 years after that, I became an accidental and reluctant chairman of the board. And then I thought, well, maybe I need to learn something about healthcare. So I went back and did some graduate work and some research. And from that, it led me to transition from chairman to CEO. When I became CEO of our hospital in 2008, we had about $3,000 a year of uncompensated care out of a $50 million total revenue, or top-line pricing. And we'll talk about pricing in a minute in hospitals. Today, that has doubled to $6 million. We had 35% of our total payer mix was private insurance, commercial insurance. And by the way, that's the only business left in a hospital that has a profit margin in it. Today, it's 23%. We had about 53% Medicare and Medicaid. And on Medicare and Medicaid, a hospital has about a 8 to 14% loss, meaning that the reimbursement is short of the actual cost. And it depends on the hospital and what the service is, but it'll range from 8 to 14% loss. And then we had, that has gone from 53% to 63%, Medicare and Medicaid. As I said, private insurance went from 35 to 23. And the uninsured is the balance. It's growing about 3%, meaning there's no insurance self-pay. And we collect about 5 cents on the dollar for self-pay patients.
So how do you
we
operate?
have an unsustainable business model. And we can't take the cost out fast enough because most of the costs are fixed.
So that is really the crux of the problem. And the way we try to fix it is through, some cost shifting goes on. Local, state, and federal taxes is a very inefficient system.
May I address the cost shifting? Because it touches on a couple of other things. So have you ever wondered how a hospital prices out something? I've wondered, and I asked the question. A hospital service doesn't come with a sticker price like a Ford F-150 truck does. And it's not consistent between hospitals. To give you a blunt and short answer, we make it up. I call it phantom pricing. Sometimes it has something to do with something. Sometimes it has nothing to do with anything. And if we feel like we're losing money on it, I say we, meaning the industry, not necessarily our hospital, we might double it. I had a surgeon that worked for our hospital once that I noticed all of a sudden his revenue just doubled in a month. And I thought, gosh, how did he do so many cases? So I started looking into it. The units hadn't changed any. Had not changed any. So I made a call and asked the question. I said, how did we increase the income so much? They said, we didn't. We just doubled the prices. And it didn't change what we got paid at all because all the third-party payers have contractual agreements of what they're going to pay for a particular service. Now, what it could have affected is someone with a high deductible or the uninsured, which is a whole nother issue of how do we price our services to the uninsured patient. We normally choose the lowest price that we have from the contractual agreements, and often that's Medicaid. So if we'll accept Medicaid as a payment for a particular service, then we'll offer that to the uninsured as well. But anyway, so we have price that's hard to define, and then we have cost, meaning what does it really cost us to service the next patient.
So a very crazy system. So shouldn't be surprised that our outcomes aren't very good. There's not much transparency in the system. We don't understand the cost, the pricing doesn't follow any rules. So what can we do if we could start over again to try to fix this system, to make it more rational, address there's some the cost of maintaining an emergency room is, I would argue, a public cost. It's a public benefit. Trauma care, I want to know, like we all know about in Georgia, if you're below I-20, you're below Macon in an automobile accident, the trauma care is very hit or miss. That's right. And you literally could die because of it. We had some funding on the ballot, and it actually didn't pass. But it's a real issue. Now, you never know you're going to need it till you need it. And so perhaps the answer is funding that capacity in a smart way, this hub and spoke system, and then taking care of the individuals so that they can get access to primary care for those non-emergent issues that you're talking about. Does that some semblance of a plan emerge that would move along those lines?
Well, I think the key is how do we figure out a way that everybody's got some basic insurance so we don't have to engage in cost-shifting strategies. By the way, back to the surgeon story, all those years ago, we immediately reversed that double pricing to go back to our even pricing. Hospitals have been forced to engage in a strategy, whereas if we can pass higher costs onto the private insurance rolls, we can get more money from the private insurance carriers for payment to pay for this uninsured care or the uncompensated care. That strategy doesn't work anymore. All the insurers fight every day to keep their costs down or what they pay hospitals down so that they can hopefully lower premiums to the insured. So Kelly, the question is, how do we figure out how to get enough reimbursement to pay for that individual that's coming through the emergency room?
So
and have some transparency.